Younger or older? Yes.
Younger. Sorry. I was honest.
It's actually give me a detriment when I canvass in the office. People will answer your door.
Yeah. Damn it. Actually. Here. Oh, so are you? Yeah.
Yeah, I'll do it.
So these are your guys? They're fantastic if they sit back there. What's that? They could sit right back. Yeah, and I think that.
Do we need any more chairs for you all, or are there enough for everyone? It looks like a perfect number. Okay, great. Lobby folks. Oh, yeah, of course. I used so I'm glad we got as a policy analyst. Yeah. Yeah. I'm great.
I'll eat food too. Please. Everybody.
We're not gonna have people sit for the rest of the house now. Yeah, and legislators at the table. I think I got food on it, I'm sorry. Not your poem this morning.
I love that poem and nobody knows about it. I'm like,
Never heard it.
it's such a good, that's only half the poem too.
I'd really like to read it. Would you be able to?
Thank you right now. There you go. It's that last line that,
Gets you.
oh my God.
Yeah.
Good. Written in the 1830s.
That's really. So everybody loves car. It's huge impact. Our car. I need my chairs.
Okay. Before any event.
Can you hear me, Dan?
Yes, I can. Thank you.
Sally, can you see me?
Yes, I can see, I can hear. This is the best technology I have experienced in a long time.
I know I'm supposed to look at that little thing, even though my instinct is to skip you, but so you know, that's where the camera is, like right in the.
I am
Thank you for
really,
being here. You know?
Leslie, I'm really, really sorry not to be there. I
I'm really happy
apologize.
that you're safe. I'm sorry you're not here too, obviously, but there'll be more time in the future. And God forbid something happened, I would never. You're
Well,
good.
it is just a sheet of ice over the roads here. Unbelievable.
That's what I've been hearing, so. Decision. But you're missing the food.
I know, that's really why I'm sad I'm not there.
Good food.
Very happy. Thank you for that connection. Like, of course, with different website and videos that we did. It's really, right?
I find that like sort of psychic up here. Sally's restaurant that opens. Just opens my eyes in ways.
It's really conceptual, but really hard to figure out what to do. Right. What's your name? Oh, hi, sorry. You'll get to meet Elena. Yeah, Sarah. She's one of our steering committee. Right. Goodness, I will say. She's an amazing person. So fun to work together. It's really great. really great. So, you know, once we watch today, it's sort of like, what's really gonna happen?
Yeah.
But we'll see.
Yeah, that's gonna be the, mechanic.
Feel free
Lena?
Okay.
Is it good?
Worthy.
Thank you. Thank you for feeding us. Better than typical caucus fare.
That was,
I get Dora a lot.
yeah, so if you guys go
Brilliant. Thank, you know, she knows. Circus, kind of the circus. Surfaces, right?
well done. It's really like. I know, it would have been nice to.
I love that poem. I'm glad people like it. Not enough people have heard it. Poet. 1830s, Sarah Williams. Yeah.
You're gonna be asked to do something.
Yes.
Yes.
Usually I think.
Like this, yeah.
Hi. Yeah,
Thanks for that.
No, this is great. I'm missing out.
So funny seeing you here.
So freaking excited for this.
Sounds good. Yeah, that's It's Friday. Doing good.
Much better than pizza.
100%. Hey, look. That is, this is me. You can sit here. I think this is, yeah. Well, the old that you posted is getting into, as a bassist, I didn't say anything, like, outing double bass territory. The viol,
I love this.
the large violin.
Oh, yes. The viol, my uncle.
Yes, it was impressive,
Yeah, that thing's big.
but don't,
All right.
bassists have so little.
That's right. Yeah,
Grew up playing the double bass. We don't even get stools.
I love the double bass. Too big for me. Yeah, I played some of his viols years ago, but I never
Did you?
tried that one. Yeah, we used to do like some Christmas.
That's the thing.
Thank you. Used to give Christmas concerts and things like that. Lynn was in the Bay Area for years, where he was the artist in residence at a small college called Minixon College.
Oh, okay.
And he, he just gave him workshop space. He was like built instruments and,
Self-taught?
oh yeah.
Wow.
Yeah.
That's amazing. I envy so much there's abilities to do that. That's like the apex of woodworking in my mind.
Thank you, Esme, for the.
Yeah.
I mean,
You gotta leave this.
You got it. You got it through.
the idea of
Make it real lutes.
namaste.
Because in the 70s, lutes was basically
Yeah.
a guitar
Yeah.
in the shape of a lute. Because Lynn really went to the old Renaissance paint and really got the details. And to the point that he even took this instrument called a primer, a crumb.
Bad press.
And it was like a saxophone at the bottom. He was like, how do they accomplish the bell?
Yeah.
Because there wasn't.
I used
any
for the
Oh my
So he
God,
went
that's so wild.
someplace in the Netherlands, something, he was able, because he was like a scholar, to borrow a crumhorn.
I didn't
Took
forget
it to
about
the
that.
hospital, he had an x-ray.
It's been 6
Yeah,
years.
and he figured out that they went 3 holes, 2 down, 1 across, and that there were these little, and that there were these little kind of ornaments.
It was like in a Pez, in the thick,
It's a wonderful instrument.
It's a cool instrument.
You like big
And from Vermont called 35th Carol.
Yeah, that's what I made.
It was made from tabla and
Ecuador for like 4 months.
really great stuff.
Good players, I've seen some good Moroccan players play live.
Yeah.
It's another level.
Yeah, I'm
Yeah,
down
pretty
to practice.
And it's so interesting, like, the history of that. That into religions.
Oh, there. You got that?
So much grace.
And so do you still play the upright bass?
Other issues that I heard about.
I don't have, even as a homeowner, the space, a double bass or contrabass. I haven't played it in years. I mostly just play my acoustic stuff. Where does it sound?
Oh, way in the back.
Play one.
Way in the, I'm just kidding. Come here.
My
No,
wife.
you're my table. Across.
Second to 12th grade, double bass, and so, but my wife has never, has many double basses come across.
That's what we want.
Yeah.
There's so, and my stepdad used to like shove it into his Toyota Camry to get to.
Yeah.
It was such a mess.
I've been trying to go down, well,
I haven't
Play with
looked
a lot
at
of upright
the
basses.
spreadsheet recently.
And bluegrass is pretty much that's what the bass is.
Yeah.
Should I pull
For
it?
some of my friends who are great bass players, people can learn,
Yeah.
you know, young people. Yeah.
But they,
Most people, even like really
just
good
expressed
bass players,
interest in like wanting to be
are just learning how
informed
to
about
play.
these things, so.
I started.
They might not
but
attend today,
I
but-
didn't believe
It is an
I didn't
unusual.
try pizzicato for like 6 years.
Yeah, because like most.
Wow.
Like music, they start to bow and just know a lot of people who got pretty accomplished bass players and then started learning to bow.
I don't know. I mispronounced it. Avishai Cohen plays a jazz bassist and he was playing, saw him play with Chick Corea once.
One of the
in New York City. That was the greatest.
That's great.
I was like 16.
private.
All my friends are going to parties like, where are you going? To the city to watch a jazz. It was so good. So good.
Oh, that's awesome. Yeah, I love good. You know, what's her name? Last name is Esmeralda Spalding, maybe?
No.
She's like a phenomenal kind of jazz player. You know her? Yeah. Great bass player, just like a band leader. Really inspiring. Yeah.
Thanks, Jesse.
Charles Mingus, to my mind, still the greatest bassist of all time.
Thank you.
Agree with that.
Well, go take my picture.
So I gotta get over to you guys' work.
Totally.
I know, that's exciting. Like it really bad.
That'd be great.
It's documented everything. Okay, so that's my level of.
Oh, yeah?
Yeah.
Whatever reason.
That's great.
Bound to happen.
Hey, look what I'm repping.
Without a guitar, right?
I brought it.
I'm selling my nice guitar and I don't want to get the sell before I buy it. Another one.
How are you?
I've been a bummer now with that
And
guitar.
Oh my God, Jonathan, I
Three
like
months out. It took a while for them to get it ready to sell.
I don't,
Yes,
no.
you fell earlier.
No, it was like, I have bought a lot of like Vermont made instruments over the years from like new builders. And Adam was another one of those.
But it's never
You
gonna.
know, I bought it. A guitar.
Oh.
And so I'm selling it. And I think it's like I need a professional level violin.
But so the help,
I've got
yeah,
3 or 4.
yeah.
This was I'm
That's the
buying.
everyone,
Oh.
they're started. Oh,
Are you gonna sell a guitar for?
I mean, it's so fixed.
Okay.
Thank you all so much for being here today. My heart is swollen with pride and joy and excitement for just the potential. And I don't want to get too excited. The hard work is yet to come, but I just feel really grateful to everyone for being here, our incredible speakers, legislators who are all inspiring me on a daily basis, our students and the Vermont Public Health Association folks. So thank you so much. I'm just gonna introduce our Public Health Caucus today. So that is my job and I'm very excited to do it. My background is largely serving youth, so that's part of my passion for this, and more recently in substance use prevention. And I have just seen the power of public health as a tool to affect change that can impact entire populations, which to me is just so inspiring and powerful. I think about how we solved the cholera problem in New York City by treating the entire water system that everyone drank, and how you can apply that to all sorts of issues to affect change. Why do we need a public health caucus? Legislation, by definition, affects entire populations, and even if only indirectly. And as we've been told many times, all the decisions that we make, there are winners and losers. And sometimes the decisions we make might suppress health, and a lot of times we hope it will support health. So if we can use that focus in the work that we do, I think we could make some progress in some issues that are challenging us right now. And I know lawmakers are really busy a lot of times, and we spend a lot of time in our committees. So with this is just that we would be able to connect some of the work that we're doing with that public health lens and how you can affect entire populations at the same time. Public health is a nonpartisan and research-based tool. So that's also exciting, I think. And it's based on evidence, and we can use that as we look at issues and examine policies. And one thing that really I think about a lot is chronic disease. It was estimated cost us $1 billion in Vermont in 2022. And a lot of that comes from behavioral health issues. So things that we can change if we can make policy decisions that would support better outcomes. So I think we could use that money for a lot of other things that we want to do. And that would be a good outcome eventually. And I hope that we can, this is really the start of a process of using this tool to look at things better. So thank you very much. And I will leave it to our first speaker, who is Dr. Mark Levine.
Well, actually, I'm
Sorry.
We're able to pivot. We have snow, we have someone on the screen, which we didn't expect, so we're all good. So thank you, Kate. You're going to hear a lot of themes echoed in what I'm going to say, which Kate just said. So according to the expenditure analysis in 2020, the percent of the gross state product from healthcare was 19%, with a total amount of $6.36 billion. That is a huge portion of our economy. It seems reasonable that if we had a healthier population in Vermont, we would need to spend less on healthcare. That money could be used for Vermont and for Vermonters. Public health, as defined by the WHO, is a path towards a healthier population. So, what is public health? And in addition to potential cost savings, why should we care about it? This is the question we put to our panelists today to help us begin our conversation of how we use the lens of public health to improve the health of our population. So we have a little postcard if anyone didn't get one and would like one. So this is what you're gonna see around. Just because we think the lens of public health, as Kate said, can apply to so many more things than we actually think about it. So our panelists are going to address that question. And we have three panelists, Dr. Mark Levine, Commissioner of Health, State of Vermont. Thank you so much. Elena Berube, who, right papers, is the Director of Health System Finance at the Green Mountain Care Board. And Sally Kraft, Dr. Sally Kraft, who's a Population Health Officer at Dartmouth Health. And Sally really wants to be here, but the roads made more sense for her not to be. And we really think that was a really right public health decision. So we'll start with Dr. Levine and then Elena and then Dr. Kraft.
Good. Now, try to keep it to the 5 minutes.
5 to 7.
Yeah. It's really hard to talk about public health.
No kidding.
Several things just resonated right off the top of the bat, which I know certain committee chairs understand very well, the word nonpartisan. So though I appear to be like a clone of the governor because he appointed me, I am nonpartisan when it comes to public health. So I try to speak truth and data and science, because that's the grounding of public health. And then I always love these sort of return on investment kind of propositions where we're spending $1 billion, but in 6 years, we'll save 10 billion. But those are really tough arguments to make, unfortunately. And it's not just here in Vermont, it's in society in general, across the country, across the world. So despite the fact that we all recently lived through the public health emergency that we know as COVID, it's not always clear to the public what we mean when we say the words public health. Now, public health likes to be behind the scenes. So we're not exactly out there holding the flag all the time and, bragging about this, that, and the other thing. But there are times that we become very visible, and we'd like those opportunities to show the best of public health, obviously. And hopefully the pandemic, at least we know in Vermont, did that, though I shudder when I talk to my colleagues around the country. So I have to start when I'm talking to sort of broader audiences about public health to always make the clear distinction that public health is not health care. And it's not the healthcare industry. That's an industry that I'm part of. I'm a doctor, but it's an industry that, though we do talk a lot about prevention and trying to keep people healthy, we're predominantly involved in treating people who are sick and being disease focused. And so public health actually aims to keep people out of that predicament, whether it's sickness, whether it's injury, you name it. So instead of being disease focused, we're very prevention focused and health and well-being focused. And I heard the WHO mentioned, and their whole definition of health involves the words, mental, physical, spiritual, emotional well-being in health. We also, unlike most of my career, are focused on populations, not on individuals. Although to the credit of those who are now running large healthcare industry, there's a greater understanding of taking a population-based focus if you want to make any progress, especially in reducing costs and improving the quality of care and services. And in fact, if the words triple aim ring a bell to people, those are, the two that are always well known are cutting costs and improving quality and service and all of that. But the third one is population health, to which most people go, huh? So public health, by the definition we use and literature we publish, is the science and art of preventing disease, prolonging healthy life, and promoting physical and mental health of the whole population. So who should care about that? Early prevention obviously can prevent serious and expensive healthcare problems later in life. Best way to understand public health is really through examples. So we did, as you know, just come out of COVID. We learned a lot about how we investigate disease epidemics or outbreaks and prevent their spread. And people got to live that and appreciate it firsthand. They really, I don't think, understood that that wasn't like novel for us. The virus was novel, but the process wasn't. And indeed, there's a lot of infectious diseases, and a lot of them involve foodborne illnesses. Some are environmental, whether you're talking about ticks or mosquitoes. Some are sexually transmitted, but it's the same work. It's just you have to adapt it to the type of infectious agent you're dealing with. But people are pretty familiar with the infectious disease part of and the epidemiology part of what we do now. But there's a whole lot more. We improve access to healthcare services that are prevention oriented, whether it's getting immunization, whether it's getting a screening test for cancer or cardiovascular disease, whether it's prenatal care. We operate across the whole life cycle, although I do think public health traditionally was very maternal child focused. And I think we've been able to move beyond that. Not that that isn't critical, but really, we want to support child development, child nutrition, school and adolescent health, reproductive health, and then the newest entity, I saw Representative Noyes somewhere, prompting me, kicking me, the whole bit about healthy aging and living in healthy, age-friendly communities. We promote healthy behaviors, which are the number one thing to prevent chronic disease, whether we're talking about physical activity, diet, or avoiding some of those things like tobacco and other substances. We connect people to recovery supports and treatment services when they have substance use disorders. Much like the pandemic and everything that's happened in Vermont this year with flooding and you name it, we are very involved in emergency preparedness, providing guidance around chemicals in the air and water, addressing the impacts of climate change on our health. We have some sort of mandated responsibilities like inspecting food and lodging kind of establishments, forcing health regulations at the local level, if you will. We also have a broader role in licensing various healthcare personnel like physicians, medical personnel like EMTs, and of course, we're very involved with hospitals. Everything public health does, as I opened with, is very data-based. We are the data geeks, if you will, tracking outcomes on anything that needs to have an outcome tracked on, and practicing what we can just talk about later if it comes up, evidence-based public health practice. Just like when you go to your doctor and the medicine you get, you want to know that there's rigorous trials behind it and it's appropriate for you, or the screening test you're going to get. The same thing we do in public health has to be true as well. We collect data on a whole range of topics to keep track of the health of our state. We publish a state health assessment every several years, which we're actually redoing right now, and a state health improvement plan based on that health assessment. And that's really critical to informing us and all of our partners. And in the new definition of public health, we don't just sort of look at epidemics and work on environmental pathogens and defeat chronic disease. Everything we do is partnering and collaborating, because public health can't do any of this alone. Whether we're partnering and collaborating with the executive branch or the legislative branch or the judicial branch for that matter, whether it's with community partners and leading organizations across the age spectrum and across anything, whether it's government sectors, not only within the Agency of Human Services, but transportation, housing, agriculture, you name it. That's how we work. In our Department of Health in Vermont, we have a public health laboratory, we have a medical examiner's office, and we are a central operation. So we have 12 district offices throughout the state, but they're not independent local health departments. They are really the boots on the ground for the health department in the local setting. And they are, of course, critical to local community partnership development that fosters our success. And so throughout this whole broad range of programs and things, we are very, very focused on health equity. That's sort of front and center in everything we do. We know that people's health are shaped by the circumstances in which they grow up in, learn in, live in, work in, you name it. And we know that some people in Vermont have way more opportunities to be healthy and have a higher quality of life than others. And the whole definition of health equity is having that fair and just opportunity to be healthy. So we are continuously looking at populations in a very focused way who don't have that same fair and just opportunity. Lastly, we collaborate extensively and frequently with our sister departments in the Agency of Human Services. They include children and families, mental health, disability, aging and independent living, Vermont Health Access, and corrections. As well as I mentioned, bringing what I call a health in all policies lens, which is nicely illustrated on the card, to our work across all government sectors. And so we appreciate you developing this caucus and our partnerships in supporting this work and protecting the health of Vermonters.
Thank you. Thank you. You all may be wondering why you have a card in front of you. We just want to say that if any kind of, this is our inaugural moment. So we're going to be taking a path, but we don't know what the path quite is yet. So we're hoping if any kind of questions, ideas, thoughts, concerns that you come up during the course of this few more minutes, write it on the card, and then we're going to put them all together and see where we go. So fill out your card, please. All of you, and especially the young people over there, because this is in a way why we're doing this. Someone like me, it's going to be okay. But for you, it's going to be more. I'm not going to be around to watch.
That sounds fair.
But you get my point, right? It's up to the young people. So next, we'll have Elena. Go ahead.
Great. Yeah. Thank you for having me. It's just so exciting to see so many vibrant, excited faces that tackle some of these really imminent challenges. And I do want to recognize I prepared my comments with two hats. One is the Director of Health Systems Finance, the Greenmount Care Board, but another is as a researcher and academic who's really interested in how we kind of expand healthcare and population health, and that we're really maximizing this for all people, and what are the systems that need to be in place to achieve that. So I'm going to start with why we should care about it. Disparities in health and healthcare are getting worse. Our life expectancy is decreasing despite spending so much more money on healthcare, and this is concerning. We see it across populations in terms of race, in terms of income inequality. These are many of the metrics that our colleagues at the Department of Health track, and trying to understand kind of the reasons and the drivers of that is a very complicated process. And so, as you'll note, public health is more than just a department. It's more than just, people on the ground doing the work. It's really about how all of our agencies, our laws, our social, our economic factors are all coming together to, for how people experience health and healthcare. So, thinking about parents and am I going to be able to go to work today because my children are being taken care of, childcare, income, am I going to be able to feed my family nutritious food? And am I going to be able to continuously do that? Or do I have this, weight of stressors kind of bearing down on? And what does that mean for my mental health and the other ways that I can participate in society? So I kind of want to push you to think about what we mean about public health in a broader sense, and really, everything that we do has implications for how our Vermonters experience health and are able to remedy what's not working in their lives. So we have an opportunity in our small state where we are so collaborative to really be creative and how we think about that. And there's a real opportunity to setting the light for the rest of the country. So I just want to underscore that. I think in this vein, thinking about systems that we create and thinking about prevention and thinking about, once people are ill, where can they go and how are we using our resources? We spend an incredible amount of money in this state on healthcare compared to other states. Part of that is size. It is hard to be efficient when you have small numbers, but part of that, I think we should take a long and hard look about how we're allocating our resources. And from the board's perspective, the board is here to kind of track, monitor, evaluate, and regulate our healthcare spending dollars in accordance with kind of the state's objectives for how we're going to make these reform efforts and rethink how we allocate our spending. So, part of that is just having great data to understand what's happening, having analytics that drive insights for where we should be moving and how we can reallocate resources. Are Vermonters getting appropriate screening? Do they have access to the care they need when they need it at a cost they can afford? Do they have coverage that allows them to get the care that they need? What else are they sacrificing in their lives because they can't afford to have their coverage or their employer can't continue to offer them the level of coverage that they need? These are all very important questions that we'll have to work together as a state to solve. Are people showing up in the hospital because they don't have access to care when they need it? We need hospitals, but are we overusing services because other parts of the system aren't working? How do we understand that and kind of disentangle the threads? And how do we do this in a way that is fiscally responsible, but yields the best outcomes for Vermonters? That's really the point. So, I think the other thing is, how do we continue to be non-political in healthcare? How do we continue to create systems that prioritize Vermonters and Vermonters' needs over, other parties at the table? We need a strong healthcare system that is able to be nimble if, in the event of, God forbid, another pandemic, but, we don't know what's coming down the pipeline. So we have to make sure that we're ready to respond to whatever that is. We also can't, double the size of our infrastructure in fear. So we have to kind of think about what the right level is. And then, I think I just want to thank the health committees too for having the foresight to really start this work in the passage of Act 167 and thinking about what Vermonters need and going out and asking Vermonters what they need and what's working for them, what's not working for them. And I think building on that work and what comes next will be absolutely essential to solving some of these problems. And then I just want to implore you to think about and reflect why do we see a mismatch in what Vermonters need and what they say they need and what the system is, the collective system is bringing to them. Because if we don't ask why, we're not going to be able to solve those root cause problems. And I think making sure that we hold the public interest first as we're solving those problems and asking those questions will be absolutely essential. And then, just one last point, it's thinking about concepts and improving health and reducing disparities is one thing, but I think we need to connect those concepts with the implementation plan. So bringing the parties to the table who are on the ground, who know what it takes to move the needle, who knows what it costs and what resources we need to make this actually work and stick. It's going to be important. Turn it over to Sally.
Thank you. So now we're going to pivot over to Sally, who's on our screen, Dr. Kirchner, Population Health Officer from Dartmouth Health.
Great, thank you very much. And I really apologize for not being there, but I may have ended up in a hospital if I had attempted to drive up there. So my apologies. The disadvantage of going third is that really Mark and Elena have already said everything that needs to be said. But let me give it to you in a little bit of a slightly different framework. And for this talk, I wear two hats. I wear a hat of a physician who I've spent my life practicing in critical care units, as well as leading system quality improvement and redesign in the hospital. And I also wear my Master's of Public Health hat, in which I have been a longtime student of public health and what that means. And I'm going to tell you about 3 stories that will have 3 points. The first point is 80%, and we'll talk about why your zip code matters more than your genetic code. That the reason that we should all care about that is none of us in this room can be as healthy as we possibly can unless all of us are as healthy as we can. And the third thing is to think about this like one of the Vermont streams or New Hampshire streams that we love to hike along. From downstream to midstream to upstream, the challenge ahead of us is to connect those parts of the stream. So let me put some context to that. I'm not going to talk about public health. I'm going to talk about our public's health. And there's a difference. I am a student and a practitioner of population health, which means I look at health outcomes across populations and the distribution of those health outcomes across the groups, which means health equity. Why are some people healthier than other people? And most of us, as Mark mentioned, Dr. Levine mentioned, when we think of health, we think of healthcare. But Dr. Levine has eloquently talked to you about the importance of the public health system. But I'm going to say that it's neither one working in isolation, but both put together, and many other players who don't frequently get called to the table to help us out. Schools, employers, churches, that whole group of people that shape the places where we work, live, and play. We're failing. We are utterly failing in the United States. We spend more, as you've heard, than any other country, and we have some of the worst health outcomes, including life expectancy at birth, compared to any other developed country on the globe. Our life expectancy is falling in the United States. Actually, it took a little bit of a creep up in the past year, thanks to the decreased death rates from COVID. But overall, our life expectancy has continued to fall in the United States. And that's in contrast to other developed countries. And this was happening even before COVID. Why? Many reasons why. But I pull forward the information which are in the death rates due to what we call the deaths of despair. These are deaths from suicide and overdose. Really? We live in a society where suicide and overdose and poisonings are alcohol poisonings or drug poisonings are a major contributor to the loss of life expectancy. Our US health system is failing. We are critically ill. Not only do we consume 19% of the gross domestic product, but we are continuing to operate under very constrained resources. And when we needed our health systems most, which was during COVID-19, you saw an unprecedented number of practices and hospitals closing because the financial way that we pay our healthcare providers, our healthcare systems is toxic. We pay for sick care and not well care. So when people didn't come into the hospitals and didn't come into the clinics, revenues dropped. And we saw that particularly in our rural areas where we couldn't stay open, even when our population needed us most. On top of it, everyone's read about the unprecedented rates of burnout and depression amongst the workforce, professional despair, and people leaving the healthcare workforce in ways that we have never seen in the past. And then both Dr. Levine and Alina commented about the health inequities. In the United States of America, Black women have a maternal mortality rate that's 2.5 times greater than white. How can we live in such an unjust country? And we've seen it particularly in our rural areas here in Vermont, New Hampshire. The life expectancy and death rates in rural populations are greater than urban, and that difference has gotten bigger through time, not smaller. So why? And I think that's the question that we really have to grapple with. Why do we have these kind of this report card on the US health system? I'll hypothesize, and I don't think this is any insight that others haven't voiced, but 80% of our health is driven not by healthcare, but by the conditions in which we work, live, and play. It has everything to do with who loves me at home and takes care of me. What's my income? What education level did I obtain? Do I have access to a car? Do I have a good job with good benefits and a livable wage? What's my housing situation like? This has nothing to do with healthcare. It has everything to do with what you have heard referred to as the social determinants of health. I don't like that term. Those conditions don't determine our health. They drive our health. They impact our health. So 80% of our health outcomes, how long we live and how well we live, are driven by behavioral and socioeconomic factors. This leads to the aphorism, your zip code matters more than your genetic code. Why do I care about your health? I care about your health because very much like what happened in COVID-19, which I think really drove this point home. In COVID-19, we all cared about who we were living with, who we were interacting with, because if they had COVID, we had a good chance of getting COVID. In fact, the WHO, the World Health Organization, said, no one is safe until everyone is safe. And I'll postulate to you that I don't think anyone can be as healthy as they possibly could unless we're all as healthy as we possibly can be. Your poor health is definitely something that I myself and you all as taxpayers and as employers are invested in. We want our workforce to be healthy. We want our places of employment to be places where people come and can be active and present and as productive as possible. So for our communities to thrive, for our workplaces to thrive, we need to have healthy populations. So I would say that none of us can be as healthy as we possibly can be until we are all as healthy as we can possibly be. And thinking about how best we can do that, I'd like to walk you along a Vermont stream or New Hampshire stream, depending on which side of the Connecticut River you live on. But let's take a hike along a Vermont stream and think about what's happening downstream, midstream, and upstream. Downstream is where I work in the intensive care unit or I work in the clinic. It's where people come for healthcare services. In the middle of the stream are those community resources we have. Do we have a healthy environment? Do we have access to a Boys and Girls Club? Do we have access to schools where we can provide healthy, nutritious meals during the school hours or breakfast? Do we have employers who are here and anchored in our communities, providing jobs and offering economic opportunities for people? It's that middle part of the stream, which is the community part. It's where we all live, work, and play. And then upstream are the policies, the laws, the legislation, the regulations that impact all of us. I like to talk about upstream as the political determinants of health, even though I recognize that some of them are financial. But at the end of the day, I think it's what's happening in state capitol buildings or in Washington, D.C. Those policies and regulations and payment mechanisms that impact our schools, our employers, our healthcare systems, impact that entire stream. And it's those historical political determinants of health that drive racism, ageism, stigma related with socioeconomic status. It's those long histories of policies and practices that have made a difference in our ability to achieve full health for all of us. So I would ask us to think about not just public health and not just healthcare, but really our public's health. How do we collaborate and work together in new ways, in ways that we've never done before? My MD hat and my MPH hat are frequently have the bills pointing in different directions. We've got to get things lined up. I'm very excited about one of the experiments that we're doing at Dartmouth Health called the Center for Advancing Rural Health Equity, bringing researchers, educators and students, clinicians and communities together. The acronym CARHE was not a mistake. It's pronounced CARE. I think this is the way of the future. How do we work together? How do you in legislative positions or employers or financiers of health, how do you create the incentive structure to bring us together to work as a team to address not only the downstream and the midstream, but also the upstream drivers of health? And I'll end on that note, and again, apologize for not being with you in person.
Yeah, thank you so much, Dr. Kraft. I think that maybe we all have so many questions that we just gonna have to write down. So that's what your cards are for as we go forward, and hopefully someday you'll be back in person. Is what I hope.
I have the honor of introducing to you Dan Olson, who, if you haven't met, is has been a terrific partner to us, has helped be our backbone as we've gotten all these things organized, and is just a fantastic leader. Dan has a very impressive resume, which I will not read the whole thing, but he's had a lot of work in high-level policy positions in nonprofits, and I believe also climate change has been a focus as well. So thank you so much for being here, Dan, and let you take it away.
Sure. Hi, everybody. I got the shortest speaking spot here, but I had to win a room over quickly. I offered to bring the food. So if you enjoy food, that comes from Namaste Indian and Pali Kitchen just down the road. So go in and say hi to Nick and his crew there. So my name is Dan Olson. I'm the relatively new executive director for the Vermont Public Health Association. We have a number of board members scattered throughout the room who maybe you've had a chance to interact with. Our role is in Vermont, we've been around since 2002, and we're a membership-based nonprofit to help support the public health of all Vermonters. A lot of that entails education, and that's why we're so excited to help support the work of this caucus in any way that we can. Importantly, for our ability to do our work, we don't exist by ourselves. We exist within a broad ecosystem. We're an affiliate of the American Public Health Association. And correct me if I'm wrong, is that every state has an affiliate? Almost, except for West Virginia. So almost every state has a state affiliate of the American Public Health Association. And we are that for Vermont, which taps us into a very large network of resources back in DC, but really a network of other states and how they're experimenting to improve what's working, what's not working in their states around public health and public health policy. So with that, I'd actually like to introduce our guest, who I'm sure traveled the farthest with the most difficulty.
Good public health rules.
Susan Pollan is the Associate Executive Director at the American Public Health Association. And when we've talked to other people around the country about what Vermont is trying to get off the ground here, there is a lot of excitement. And APHA was happy to come down and to share a bit of a global perspective to put context for what we're doing here, or add the context of how does what we're doing here fit within a national context. Susan called me at 7 o'clock last night, 8 o'clock last night. Her flight was canceled. She rerouted to Manchester and drove 2 hours this morning to be with us here, three hours. So please help me join Susan today. Thank you so much for coming.
Hi.
Yeah.
Thank you so much for being here. Thank you, Dan. You have no idea how excited I am to actually be here. I did not expect to make it when I got that text from American yesterday evening. So let me tell you just a little bit more about the American Public Health Association. We are a membership organization. We have about 50,000 members, including our affiliates, organizational members. We have affiliates in every state except West Virginia, but we make up for it for having one in DC and one in Puerto Rico and 2 in California. So I have been with APHA as of yesterday for 19 years. And I really have learned to appreciate what happens at the national level, but also even more importantly, what happens at the state and local level. Among our 50,000 members, about a third of them are students and early career professionals. So shout out to you guys for being here. Students are so important to the work of public health. And we really do appreciate everything. Within APHA, we serve as a convener, a catalyst, and advocate to build capacity in the public health community. So what does that mean? We recently did a new strategic plan, and our mission is to build public health capacity and promote effective policy and practice. But even more important is our vision, which is optimal, equitable health and well-being for all. So you've heard a lot about health equity. You've heard a lot about disparities, and that really is the crux of much of the work that we do. We speak out for public health issues and policies backed by science, which is critical. But we also are the only organization that combines that with a 150-year perspective, our member community, and the ability to influence federal policy. And Dr. Kraft, I think, is still here because our ability to influence federal policy really does focus on the public's health. We're not there making sure that the public health professional is paid enough. That's important. But the real issue is to move upstream and ensure that folks are getting the services that they need. As Ben said, we're the voice on the national voice on public health, but there is the flip side. We could not do this without our affiliates. Our affiliates are on the ground. They are offering the complementary efforts to the work that we do at the national level. Our first affiliate started in 1918, and we have developed, and Vermont is one of the newer, but not the newest that we have. And so we're always so excited to be able to work with folks as they are working on some of the same or similar goals. It's really our affiliates and our members who are in every state and across the world who keep us abreast of what's happening in the day-to-day work in the ground. And with that perspective, we see both so much good and so much bad. And I'm going to start with the bad. It was exacerbated during COVID, but what's happened for years is there have been attacks on public health and public health authority and the evidence and science that we use to make decisions. There have been an increasing call out on restrictions on vaccines and vaccine mandates. And we all know chronic disease is the #1 killer, in part because we've done such a good job of controlling the communicable diseases that vaccines allow us to control. We have seen attacks on public health authority. So would someone like Dr. Levine be able to make the decisions for the public's health and Vermonters' health in other states? In some states, those are not, that position is no longer receiving both the respect and authority that it deserves. And so that is something that we really are focusing on. But I want to actually pull out something that Dr. Kraft said and in some ways contradict what both of you said, which is public health is political. It's not partisan, but it has to be political because policy is critical to improving the public's health. And that's the work that has to happen. And that's one of the reasons why this caucus is so exciting. I did some work before I was coming up here to look at what's going on around the country in other legislatures. And in Illinois and Connecticut, there are public health committees, and that's just a regular committee, important as it is, but it does the work of the legislature. In Maryland, Massachusetts, Indiana, Kentucky, and Michigan, there are commissions that have been formed that are a combination of private and nonprofit, but it's external to the legislature in terms of the education and priority setting. So states are looking at public health and how to create healthy people and healthy communities. And doing that in a way that is really important, and which includes both the legislature, governmental public health, and non-governmental public health. And all of those voices have an important role to play at the table. But I have to tell you, very much like the conversation I had with Dan when he was calling me from a yurt on Monday, Vermont does things differently. And that is actually incredibly valuable. And you are a leader in the country with this. And I really want to congratulate you. There's no other state in the country that is doing what you are doing here with this Public Health Caucus, where state legislators are coming together and doing the education, doing the priority setting, and trying to help their colleagues understand what public health is and how to do it better for the residents of their state. You're bringing together the NGOs like the Vermont Public Health Association, and hopefully as you move forward, bringing together the communities and the people that you represent to hear from them about the importance of the policies that you pass and the things that you reflect on. This caucus is the best example of elected officials leading the way. And we really do want to help you in any way that we can, help the Vermont Public Health Association in any way that we can to build this infrastructure to make the changes in policy so that the upstream population-based approaches to improve the health status for all residents of the state can happen. And perhaps along the way, you in Vermont can regain your #1 status in the state health rankings. You're still #3, but I know you try harder, so we're more than willing to help you do that as well. I end most of my presentations with a picture when I'm doing a PowerPoint, and I don't have that, but I want to give you a visual of what that picture is. It was actually taken by a friend of mine at the 2021 March in DC. And its sentiment is relevant to everything in public health. So the picture is two young people walking. One woman is, one of the people is carrying a sign. And they happen to be walking in a bike lane. So in front of them is an arrow pointing forward. And the sign says, this is a marathon. So I want to thank you here in Vermont for taking the lead in the marathon that we know is public health and showing us all the way to move forward. Rest assured that other states and other affiliates will be hearing about this. Then you should expect a bunch of calls. But really, I want to thank you because you are making a difference, and being here at your kickoff is such a pleasure, and we're so excited. So thank you for your time. And I am here, even if I'm not here, if there's anything we could do to help you as you move.
Thank you. Thank you very much. We're running out of time. We have actually run out of time. Because we all have to get to committee, those of us that are serving on the committee. So we will do that. Our next step is to read a card. I hope you had some questions or something that you want to contribute as we move forward. We're going to be meeting every 2 weeks. But we don't know what our next agenda is, but I'm sure you'll hear about it as you've heard about this. So thank you, and contact any of us. If any of you haven't seen this, all our names are on it. Who to contact if you have questions, and help us figure out how to go forward.
Thank you.
Thank you. Thank you all for coming. Yeah, that's a good one.
Wrong by the name of the bass player. I always thought he'd rock you. His first name's Esperanza. Esperanza, not Esmeralda.
Thank you.
Yes.
One of your pickles or coffee or whatever.
They said that. I was like, no, that's not quite right.
You play violin. I play mandolin.
Oh, yeah.
Hey, Matt, over here,
I
right?
stand there too.
Sure.
Yeah, I did. I picked up mandolin. I picked up mandolin when I was about 19 or so. I played it a lot. I mean, that's the other thing I play gigs on with mandolin. Yeah, I mean, I don't know a lot of very good mandolin players around here. Yeah, I mean, you know, a number of people in Nashville. Like, we got some like, played a show 2 nights ago with this mandolin player. Absolutely killer. Like, he is, I don't know. He didn't want to.
The built-in practice, interacts with this. I mean,
But anyway, yeah, I do play. Yeah. Yeah, I'll be bringing in sometimes.
You appreciate mandolin.
Oh, yeah. I like it. You know, it's like a couch fiddle, you know?
Yeah.
Wow, John.
Oh, lots of people. Thank you.
Yeah.
And we are just thinking the next week or two, restarting the health policy work group. That's sort of an executive order from the some administration. And all the government. We bring the health lens, you know, into the room and try to get good things done. It's going to be all about.
As you're on health transportation, really working to.
Right.
Disability, but also